Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are joined by our third host, Dr. Mike Clifford. Welcome, Mike.
Thank you, Swapnil. Maddie, how are you?
I'm isolating with COVID, so I've been better.
It's the gift that just keeps giving, isn't it?
Yep, that's it.
That's right. Even her dad jokes didn't save her from COVID. So, yeah.
No.
So let's dive into today's episode. So today we are going to discuss about some of the blood thinning agents that we commonly use in intensive care unit. So let's take a scenario. So we have a 60-year-old lady who presented to emergency department with hypoxic respiratory failure, and the CTPA was performed, and that showed a significant pulmonary embolus. And now the decision has been made to commence her on heparin infusion. So, Mike, can you talk us through the pharmacology of heparin?
Sure, Swapnil. Okay, so this is a very commonly used agent in ICU. I know we have a lot of adult units that would use low molecular weight heparins almost exclusively, but often people are started on the unfractionated form, and we still use the unfractionated agent in our art-line flushes and in cardiac theatre. So it's used for the treatment and prevention of thromboembolic disease and obviously priming extracorporeal circuits. And it's still used in acute coronary syndromes and sometimes for pulmonary embolus. It's an agent that binds reversibly to antithrombin, or what used to be called antithrombin 3, and that enhances its ability to inhibit the various proteases in the coagulation cascade, in particular thrombin and factor 10A. Now, the curious thing about that inactivation is that to inactivate 2, you have to have heparin binding to antithrombin. So it must be quite long. It has to be longer than 5,000 Dalton. Whereas to inactivate 10A, it only requires to bind to that, so the length is less important. So that's why when you get an ampule of heparin, it's actually a mixture of the polysaccharides. So it's got lots of different lengths in it, whereas low molecular weight heparin is they take a small component of that and supinate it off. So that's why it's called unfractionated, because we haven't actually fractionated out. So the dose varies, obviously, because with weight, and you can give it subcutaneously or intravenously, and we usually titrate it to a prolongation of the activated partial thromboplastin time, or APTT, and we usually want 1.5 to 2 times normal. Bypass, we would use an ACT, an activated Kalin time, and we use that to be over 350 seconds. So we want marked prolongation of anticoagulation there. But even when you give that heparin, only 30% of what's in the ampule is actually active, and it can vary from batch to batch. It is standardized to a unit of activity, and I'll come back to that, but you can certainly have variation in patient sensitivity, particularly females on the oral contraceptive pill, or just because they have a variable level of antithrombin in their bloodstream. So there's a normal distribution curve of antithrombin. So some people are just more sensitive to heparin. And that's why you see such a wide variation in response to dosing, because it's a little bit unpredictable. In terms of units, 1 milligram is 100 international units, and 1 international unit will prevent 1 mil of citrated sheep plasma from clotting for 1 hour after the addition of 0.2 mils of calcium chloride. And if you go to the web, to Google, and look around, you'll see sometimes they talk about cat plasma. But in fact, that's because historically with the first samples that was found on the bench not to clot was the experimenter used his cat. But when you look at the international standards, we actually use sheep. It's in terms of its metabolism, it's metabolized by heparinases, which are widespread throughout the body, particularly concentrated in the liver, kidneys, and the reticular endothelial system. And those depolymerized fragments are often excreted unchanged in the urine. The clearance is actually 2 mils per kilogram per minute, which is pretty close to glomerular filtration rate, which would imply that it's renally cleared. And there is a component of it which is renally cleared, and it's metabolized by the kidney. And that's one of the reasons why with low molecular weight heparin particularly, you often need to adjust the dose in the setting of renal failure, because there is that fixed element of the drug that is cleared by the kidneys. In terms of its side effects, they're pretty predictable. You don't get marks for saying bleeding, but you would lose marks if you didn't say it. So you're sort of stuck there. You've got to say it causes bleeding because it prolongs your clotting time. But things like fat necrosis and hypersensitivity reactions are pretty common as effects on triglycerides and free fatty acids. In terms of long-term exposure to patients who are on subcutaneous heparin at home for whatever reason, things like osteoporosis and alopecia can occur. The classic side effect we like to talk about is the thrombocytopenic phenomenon, and there's an early non-immune mediated thrombocytopenia, which occurs in about 5% of people. And then there's a later sort of day 4 to 14 effect, which is called HITS, which is a function of antiplatelet factor 4 IgG antibodies, and they cause a platelet activation with thrombocytopenia and arterial and venous thrombosis. And whilst that's not the most important side effect, it's the one that we all worry about, and that's one of the reasons we tend to use unfractionated heparin, although there is a small amount of cross-reactivity. The last thing I'll mention, which we sometimes ask about heparin, is how do you reverse it? And, of course, we use a drug called protamine, and protamine is a very strongly basic molecule. It's a protein derivative of fish sperm, comes from salmon, and it has anion charges that combine with the charges on the heparin polysaccharide molecule, and it inactivates it at a 1-to-1 ratio. So the 1 milligram of protamine for every 1 milligram or 100 units of heparin activity. And that's pretty much as much as you would get on heparin, but increasingly we are using other agents to provide anticoagulation, particularly in the longer term. So, Maddie, do you know of any other agents that we are using at the moment for longer-term anticoagulation, or if we're going to transition this patient off heparin to something else, what would we use?
So I think there's several agents that we can use. You've mentioned that we do sometimes use low molecular weight heparin in sometimes transitioning someone from a heparin infusion, but then there are different oral options. So previously warfarin was probably the most commonly used oral anticoagulation, but we're transitioning more towards the novel or the direct oral acting, so NOACs or DOACs, which are now getting more commonly used. So it's something that we definitely need to know a lot about within the ICU population.
Which of those would you like to talk about?
So I can talk about the NOACs or DOACs, and I think there's mainly three that we come across most commonly within our practice. So that's dabigatran, apixaban, and rivaroxaban. So these three drugs, they're a member of two classes. So dabigatran is a competitive and reversible direct thrombin inhibitor, whereas apixaban and rivaroxaban are direct, very selective factor 10A inhibitors. So they're the two kind of classes we need to think about. So that's direct thrombin or factor 2 or direct factor 10A inhibitors. So in terms of the difference between these, we can think about that in terms of the pharmacokinetics and the pharmacodynamics. And in terms of the pharmacokinetics, in terms of administration and absorption, they're all orally available and there's no other route of action for these agents. They all have to be swallowed whole except for apixaban and rivaroxaban, which can be crushed, but dabigatran should not be crushed. It can increase its onset and potency. In terms of the absorption, they all have quite variable bioavailabilities. Dabigatran actually only has a bioavailability of about 7%. That's why its dosage is so much higher comparatively to the other two. Whereas apixaban has a bioavailability of about 50% and rivaroxaban has a bioavailability of about 100%. In terms of the distribution, dabigatran is about 35% protein bound, whereas apixaban and rivaroxaban are both much more highly protein bound, mainly to albumin. And then thinking about the metabolism, this has an impact on some of the drug interactions. So dabigatran is mainly renally excreted unchanged. So that's why it's important to know someone's renal function, and it's contraindicated in severe renal dysfunction. Whereas apixaban is mainly metabolized by the cytochrome system. So especially one of the cytochromes that you've mentioned before when we've talked about this, Mike, was cytochrome 3A4. So that's one of the main cytochrome systems that apixaban is metabolized by. And the majority is eliminated in stools, with renal excretion only accounting for about a third of elimination of apixaban. And rivaroxaban is also mainly metabolized by cytochrome CA4 and also a small amount by 2J2. It's mainly hepatic metabolism, and about 2/3 of the administered dose undergoes metabolic degradation, whereas the other 1/3 just gets directly renally excreted, mainly as unchanged substances. In terms of adverse effects, they're all very similar. So they're all category C in pregnancy, and we don't generally use them in pregnancy. And then it's similar, like you mentioned, Mike, with heparin, bleeding is a big side effect. But other side effects include just the generic GI side effects like abdominal pain. It's important to know about monitoring of efficacy of these agents. So with things like warfarin or heparin, we monitor for warfarin, the INR, heparin, APTT. But with these new or direct oral anticoagulants, there's no role for routine monitoring. Things like things like the INR is unreliable and can have variable effects depending on the patient population. The way we can monitor them, so for dabigatran, thrombin time is the most sensitive routine coagulation assay, and other options are looking at the Heparin clotting time, but this is quite a specialized test that's not readily available. For apixaban and rivaroxaban, there's specific anti-10A assays that can be used, but you need to state to the lab that when the last dose was and what the medication was that this patient had taken, whether it was apixaban or rivaroxaban, as they have a different assay. The other important thing to think about for these agents, especially in an ICU population, is reversal. So the only option for dabigatran is something called idarucizumab, which is a monoclonal antibody. Yes, I could pronounce that. And it binds to dabigatran with very high affinity. Yep. And it's given as 2 consecutive infusions. The important thing to know for this is there's no dose adjustment required in renal failure, but it binds as a 1-to-1 ratio. So in situations where someone's taken a dabigatran overdose, you may need very high levels of idarucizumab or consider hemodialysis in an overdose situation. Comparatively, apixaban and rivaroxaban, there's no specific reversal. There is something called adnexate alpha, which I think has been used overseas and used in a trial situation in Australia, but it's not routinely available. I don't know if anyone has any further, Michael Swapnil, any further information about that, but currently it's not available in clinical practice in an Australian setting. And then the other thing to note about these agents is they've got very specific TGA-approved indications. So it's mainly for prevention of venous thromboembolism after elective total hip or total knee replacement, or prevention of stroke or systemic embolism in patients with non-valvular AF. It hasn't been validated in the valvular heart disease population. It can also be used for the treatment, like in this patient's case, of acute VTE and prevention of subsequent VTE. But the thing to really monitor is patient's renal function, because for all of these agents, the severe renal impairment is a contraindication, but in terms of, because of the different metabolic pathways, the level of renal dysfunction is different. So for dabigatran, it's contraindicated for a creatinine clearance of less than 30 mils per minute, whereas for apixaban, it's less than 25, and for rivaroxaban, it's less than 15. So the level of renal impairment will make a difference in terms of being contraindication. And the final thing to mention about this is looking at significant interactions, because as you know, with all these critically ill patients, they're usually on a truckload of different medications. For all of these medications, P-glycoprotein inhibitors can cause increased levels. So this is particularly important for the azole antifungals, except for fluconazole, which is a less potent P-glycoprotein inhibitor. But things like ketoconazole or posaconazole, which we might be used, can all inhibit the P-glycoprotein transport protein and can therefore increase the concentrations of these anticoagulants. So they're contraindicated for use concurrently. So things like the ketoconazole or quinidine and ritonavir, which is used in HIV, as things that we need to think about when prescribing oral anticoagulants of these newer varieties.
Excellent.
So I think now that we've thought about some of the newer agents, I think we should think about something that we see much more commonly and people might be more familiar with, which we might transition this patient with a PE to in terms of oral anticoagulation, which is warfarin. Can you tell me a bit about the pharmacology of warfarin?
Yeah, sure. I guess the warfarin is quite interesting drug, I must say. And I got some trivia questions for you at the end of the podcast. So we'll cover the basic pharmacology first, and then I'll get into this bit of historical aspect of warfarin. So warfarin is basically a racemic mixture which consists of two active enantiomers, S form and R form, each of which is cleared by different pathways. Now, S warfarin is usually 2 to 5 times more potent than R isomer in producing its anticoagulant response. Now, in terms of its mechanism of action, warfarin inhibits the vitamin K dependent synthesis of biologically active forms of clotting factors, namely 2, 7, 9, and 10, as well as the regulatory factors like protein C, protein S, and protein Z. The precursors of these factors require gamma carboxylation of the glutamic acid residues to allow the coagulation factors to bind to phospholipid surfaces inside the blood vessels on the vascular endothelium. The enzymes that carries out the carboxylation of glutamic acid is gamma glutamyl carboxylase. Now, the carboxylation reaction will proceed only if the carboxylase enzyme is able to convert a reduced form of vitamin K, that is vitamin K hydroxyquinone, to vitamin K epoxide at the same time. Now, the vitamin K epoxide is in turn recycled back to vitamin K and vitamin K hydroxyquinone by another enzyme called as vitamin K epoxide reductase, that is VCOR. Now, warfarin inhibits this VCOR enzyme or vitamin K epoxide reductase, and thereby diminishing the available vitamin K and vitamin K hydroxyquinone in the tissues, which in turn decreases the carboxylation activities of the glutamyl carboxylase. When this occurs, the coagulation factors are no longer carboxylated at certain glutamic acid residues and are incapable of binding to endothelial surfaces of blood vessels, and thus they become biologically inactive. Now, as the body's stores of previously produced active factors degrade, which happens over the several days, and are replaced by inactive factors, the anticoagulation effect becomes very apparent. And that's why warfarin always takes 3 to 5 days before the actual effect starts. The coagulation factors are all produced, but have decreased functionality due to under-carboxylation. So it doesn't block the synthesis of the factors, it just blocks their functionality. Now, when warfarin is newly started, it may promote clot formation temporarily. So it's a bit paradoxical that it actually promotes thrombotic activity. And that's mainly because of the level of protein C and protein S are also dependent on vitamin K activity. So warfarin causes a decline in protein C levels in first 36 hours. In addition, the reduced levels of protein S lead to a reduction in activity of protein C, which is a cofactor for protein C, and therefore reduced degradation of factors 5 and factors 8. Although loading dose of warfarin over 5 milligram produces a precipitous decline in factor 7, it results in an initial prolongation of INR. The full antithrombotic effect does not take place until significant reduction of factor 2 occurs, which happens few days later. So you can see actual reaching the INR only when the factor 2 becomes inactive. And the hemostasis system becomes temporarily biased towards the thrombus formation, leading to a prothrombotic stage. And that's why we have to use bridging heparin or some other form of anticoagulation till the warfarin kicks in. So that's the kind of mechanism of action. Now, in terms of its indications, common indications in ICU include atrial fibrillation, artificial heart valves, mainly metallic mitral and aortic valves, deep venous thrombosis and pulmonary embolism, and also in patients with antiphospholipid antibody syndromes. Now, in terms of the dosing, when we start warfarin, we start at low dose and obviously titrate with INR. I guess the maintenance dose of warfarin can fluctuate significantly depending upon the amount of vitamin K in the diet. That's why sometimes when you prescribe warfarin, you have to instruct the patient what to eat and what not to eat. So the main features, vegetables that has got higher vitamin K content include green vegetables, such as parsley, cilantro, but also some of the cruciferous vegetables such as cabbage and broccoli, lettuce and leafy greens, and including peas and green beans has got a higher amount of vitamin K. Some vegetable oils also got high amounts of vitamin K, while foods with low vitamin K include roots, bulbs, tubers, and most of the fruits and fruit juices. So I guess that's why a patient need to be mindful, or also sometimes when you prescribe the diet to these patients, we need to make sure that they are not on the diet which will interfere with the INR. Now, in terms of the contraindication, obviously, if the patient is at high risk of bleeding, such as peptic ulcers, or patients are on any other blood thinners, usually warfarin is not co-administered. So for patients who are undergoing for surgery or procedures such as lumbar punctures, epidurals, usually we tend to stop warfarin and monitor INR before we actually start the procedure. And also warfarin should not be given in the patients with heparin-induced thrombocytopenia until platelet count has improved or normalized. Now, it's also usually best avoided in patients with protein C and protein S deficiency because they are the thrombophilic conditions. And in this particular subset of patients, warfarin can cause skin necrosis. Now, warfarin is also importantly contraindicated in pregnancy, irrespective of the trimester. But obviously, the risk of developing fetal warfarin syndrome and abnormalities, structural abnormalities are quite high in the first trimester compared to second and third trimester. In terms of the pharmacokinetics, warfarin is essentially completely absorbed when given orally, and it's given only orally. It reaches its maximum plasma concentration between its 2 to 6 hours. It's distributed into small volume of distribution, roughly around 10 liter per 70 kilogram, and is eliminated by hepatic metabolism by cytochrome P450 system, and with a very small renal clearance of 0.2 liters per hour per 70 kilogram. And usually the elimination half-life is about 35 hours. Now, the interesting fact to remember is about the pharmacogenomics of warfarin, because the warfarin activity is determined by genetic factors. And that's why some patients take longer time to mount the response, while some patients develop increase in INR very quickly. And that depends on the polymorphism of two genes. One is the VCOR-C1 and the other one is the cytochrome P2C9, which is responsible for the warfarin metabolism. Now, in terms of its pharmacodynamics, there's not much significant effect apart from the effects on hematological system. And key adverse event effects that we need to be kind of mindful about in warfarin, obviously the bleeding. And usually commonly used score to calculate the bleeding risk is Hasbled score, which includes known predictors of warfarin-related bleeding, includes high blood pressure, abnormal kidney function, previous stroke, known previous bleeding condition, previous labile INR when on anticoagulation, elderly as defined as age more than 65, and also the drugs associated with bleeding such as aspirin or alcohol misuse. Bleeding risk may be also increased in patients who are on hemodialysis when they are on warfarin, and also when patients are taking some other antiplatelet agents such as aspirin or clopidogrel or NSAIDs. Now, the characteristic side effects associated with warfarin include warfarin necrosis, which I mentioned before is commonly seen in patients with protein C and protein S deficiency. Now, other side effects include osteoporosis and purple toe syndrome. Now, the purple toe syndrome is usually the rare complication of warfarin treatment. Usually, it's a delayed complication, occur after 3 to 8 weeks of commencement, and usually it's due to small deposits of cholesterol breaking loose and causing embolism in the blood vessels in the skin of the feet. Now, warfarin also had several interactions with several medications that we administered in ICU, including antibiotics and antiepileptics, and antiarrhythmics. So I guess commonly used antibiotics and that has interactions include metronidazole and macrolides, and that they increase the effect of warfarin by reducing the metabolism of warfarin. Other conditions which impair warfarin metabolism include hypothyroidism, where there is makes patients less responsive to warfarin, while the hyperthyroidism promotes or boosts the anticoagulant effect of warfarin. Obviously, excessive alcohol use will boost the INR, and I mentioned about some of the vegetables or the diet, how that can influence with warfarin effect before. So these are the kind of significant interactions that one should be mindful about when prescribing warfarin. Now, I got some of the interesting questions on the history of warfarin, and let's see who can crack this. first of all, tell me where the name warfarin comes from.
I'm tempted to, isn't it some sort of combination of the name of an American university or medical center or something? I can't quite remember, but I've got a vague sense that it's some sort of university of something or other.
Very close, Mike. Very close. You're on the right track here. So warfarin, the first WARF is acronym, WARF.
Yeah.
It's for Wisconsin Alumni Research Foundation.
There you go. Yeah, okay. Good.
And the ending ARIN indicating its link to coumarin, which is the actual molecule.
Right.
The reason WARF or Wisconsin Alumni Research Foundation name got included because they funded the research by Carl Link, who actually invented this molecule. And that's why they kept that WARF as the first part of the molecule, and then ARIN was added later on as a coumarin derivative. So warfarin was first registered for its use as a rodenticide in 1948. Having said that, actually its invention happened back in 1920s when one of the veterinary pathologists, Frank Schofield, found out that cattle were dying due to hemorrhagic shock after ingesting the moldy silage, which is made up from sweet clover. And which
that's right. Weren't they chopping off the horns? They were dehorning them, and they were bleeding to death when they had their horns cut off or something.
That's correct. That's actually very correct. So I guess
it's bizarre the stuff you remember that is of no benefit to anyone. Trying to tie it into the primary to help you remember something. Trying to remember cow horn. I don't know how it's going to help you, but that's how they discovered moldy clover and cow's horns.
That's right. So the dicumarol was actually the product of plant molecule coumarin. Mm-hmm. And even the coumarin is basically comes from the French pronunciation of one of the Indian plant. So that's how the coumarin name came. But the interesting fact about it, it comes from the sweet grass. And the reason the sweet grass is because not its taste, it's actually the smell. So when you cut this grass, you get a very pleasant sweet smell, but you have a bitter taste. Now, the question for you, though, which are the two historical figures, very, very well-known politicians in the history who have tested warfarin or
tested it? I thought there was a rumor that they tried to poison Stalin with warfarin, but I don't know whether that's what you mean.
No, that's right. So is
that one of them?
Yeah, so Stalin had all the symptoms of warfarin poisoning because he was attempted to kill with the use of warfarin. And the second one was the US President Dwight Eisenhower. In 1955, actually, he was the first one to test the drug as a treatment for his MI. So there are the kind of two political figures who had experimental use of warfarin for different reasons on them. So that's my share of a bit of trivia.
I've got one for you. That the dietary elements that interact all start with G. So you've got ginseng, garlic, ginger, and ginkgo biloba. All have stuff in them that interacts with warfarin and prolongs your bleeding. So you can remember the G's. And if you remember St. John's wort with W, it impairs the metabolism, so it can prolong its effect also.
Yeah, that's right.
I think St. John wort activates the enzymes and promotes its metabolism. So John's wort weakens warfarin, whereas all of the G's make you bleed for a longer period of time. So if you remember the G's, whenever you ask your patient, the reason we know that in anaesthesia, we're always meant to ask our patients, are they on any blood thinners? And then these days we always ask them, are they taking ginger, ginseng, ginkgo biloba, or eating lots of garlic?
That is so useful. So that's pretty, I guess, our share of questions. Now we will go back to Maddie, I guess, because she's looking a bit
time for Maddie to shine in her
That's
COVID.
right.
Oh no, I'm still like a bit brain foggy. But yes, I do. I had to keep my end of the deal up. So I've got a joke. It's not great. Okay. What is Batman's blood vessel called?
Batman's blood vessel.
Batman's blood vessel.
The rat? Bloody rat? No.
No.
What is it?
I can only think of the bat vein or no, go on. What is it, Maddie?
Bruce Vane.
Oh,
you were close, I guess.
I was close, but no banana. No ginseng for me.
What is it? What is it? Bruce Wayne?
Bruce Wayne. Because it's, man. Sorry.
Yeah.
Because his name is Bruce Wayne.
Oh
I
my
love the
gosh.
fact that
Okay.
you have to explain the alliteration
I know.
for it.
I
There's
know.
the language barrier.
It just doesn't get me.
I think it's almost funnier than the jokes.
It seems
That'll be
that
the next segment, me explaining jokes.
that's right. That's right. I think it seems like I live on a different planet and you guys live on a different planet. Anyways, thanks, Maddie, and thanks, Mike, for your time.
All right, thanks,
We'll be back
thanks,
with another
Maddie.
episode
Well done.
in months' time. Till then, goodbye and
Bye.
have a nice time.
Thanks for listening. See you next time.
See ya.